I will try to share our DCB case with you. And our title is Successful DCB in Reverse Bifurcation Lesion of Main Vessel. Our patient was very similar to the previous case. He is 50 years old male admitted to ER of different hospital with very severe chest pain and ST depression in all knees, ST elevation in AVR. He has a smoking history, otherwise healthy, and he was referred to our clinic with the non-ST elevation. And ASA 300 milligram and ticagrelor 180 was given in that center. On admission to our CCU, he has severe chest pain and his blood pressure was very low, 7/40. His heart rate was 100 BPM and with weak peripheral pulses and raised in the apex of the lung. He was very orthopneic and urine output was very low. He was in cardiogenic shock, as you see. We quickly discussed our anesthesiology and we did light sedation and intubated the patient electively and took the patient directly cath lab. And we directly inserted 7F femoral sheath, and under the noradrenaline dose, we adjusted our positive inotrope dose under blood pressure monitoring, and we sent 7F EBU guiding catheter directly, and left main was totally occluded, no visible LAD or circ. We quickly wired LAD and circ, and after effective predilatation, we implanted our stent from left main to LAD crossover, and we did our pod kiss report, and at the end of procedure, patient was stable. We had timid 2 to 3 flow in both LAD and circ. This is the last image of the our procedure, and we took the patient to the coronary intensive care unit. He was followed in intensive care unit, very stable, and we extubated within 24 hours, and vital signs were better according to previous his admission vital signs. We gave because there was thrombus burden in the circ ostium. We mostly use TPA slow infusion in our clinic for high thrombus burden patients. Our results are very good. And 3 days later, we did control angiogram. We inserted 6F right radial sheath. We switched to left due to high takeoff right radial artery. You can see the image of high takeoff right radial artery. And control angiogram showed that you can see very good flow in both branches. And we suppose that our stent is from left vein to LAD crossover. It was patent, but in other angles, you can see, I'm not sure you can see very well, but our stent was straightforward to diagonal branch. And LAD is originating approximately 3 millimeter proximal to the distal part of the stent. But we have very good flow in LAD also. It seems its caliber is seen smaller than diagonal in this image. The patient was very stable in follow-up, and we discussed the situation with our colleagues. We accept that LAD lesion is critical. We decided to perform PCI to LAD, and we discharged the patient with dual antiplatelet therapy to be able to just make our program, what kind of procedure should be done. And control angiogram and PCI was planned. Couple of weeks later, we did our control angiogram and we planned our strategy. And I also wonder if you were in our shoes, what would you do and how would you name it? I also wonder that. And reverse flow technique, maybe most rational one, and reverse mini crush, T-end protrusion, or another option. But in this case, we have a DCB chance in our clinic. We planned kissing DCB in LAD, and NC balloon in D1. You can see the proximal LAD is very tortuous, and it wasn't very easy to pass the stent again. And you can see 2 weeks later, approximately, the LAD is very larger than the previous imaging. And now here we are trying to pass the LAD and diagonal branches. It wasn't very easy because of tortuosity. At the end, we could pass the lesions. Yeah, at the end, our wire passed to the LAD. And first, we did our pre-dilatation with 2.5 to 20 millimeter. And you can see when we inflated the balloon to LAD, distal part of diagonal branch went upward. And there is a malapposition due to balloon inflation. And then we did our first kissing, 3.5 millimeter in LAD and 2.8 NC balloon in diagonal branch. And after kissing dilatation, you can see the distal part of stent is very good. We use B. Brown sequent please DCB in our clinic. And then while inflating DCB, to be able to prevent deformation of the diagonal branch, we did our kissing procedure. 3.5 to 20 millimeter DCB in LAD and 3 or 8 millimeter NC in diagonal branch. And we had excellent flow in both branches. After kissing dilatation, there was a bit deformation in the mid part of the stent, and we did our mid pot and ocil repot. And this is our final angiogram. We don't have any severe dissection in LAD, and our blood flow is TIMI-3 in both branches. And I will just finish within 2 slides. DCBs may be considered in bifurcation interventions. Very nearly, very soon, DCB BIF trial was published. And it would be safe and effective. It may decrease stent burden in the carina, and it may decrease the risk of acute and late stent thrombosis. And this is, we did final angiogram, control angiogram, approximately 5 to 6 months later, a couple of days ago. This is our final result from areocranial and AP cranial. The patient is very stable, and we stopped his second antiplatelet. We are going with aspirin alone. Thank you.